Alexa Tinsley. I'm the Director of Programs here at Jett Foundation. We are here today to learn more about child life specialists. I am super excited to introduce Andrea Lerude. She is a certified child life specialist. We met actually in San Antonio at Cure Duchenne, and she was so excited to do this webinar for us, and I was so excited to have her do it because I know that child life specialists are something that we don't necessarily know a lot about. In my time as a nurse, I got to interact with a lot of child life specialists, and it was really an impactful relationship. So I'm so excited for her to share with you today. She has worked with many youth and families with Duchenne muscular dystrophy and other neuromuscular diseases. Day to day, she supported youth's emotional well-being through treatment, advocated for youth and their families coping, and facilitated youth's understanding of their diagnosis. She has a lot of experience in this space, so I'm excited for her to share what a child life specialist is in general and also in the Duchenne space. Before she gets started, I'm going to go ahead and just do a few housekeeping items. This webinar is being recorded, so if for any reason you have to hop off, if you know anybody who wanted to be a part of this webinar but was not able to, it will be available on our website, our YouTube, and Facebook later on for you to be able to share. There is a Q&A at the end of this presentation. We do primarily use the Q&A box at the bottom of your screen. It'll be a box with a question mark there for you. That's where we primarily take our questions. We do try to monitor the chat as best as we can, but if you could primarily use that, that's where we will take our questions from. We also do try to monitor Facebook and try to get those questions from there as well. But if for any reason we don't get to your question, we will forward them off to Andrea after the fact, or you can always email us and we will try to get them answered ourselves. We also do have closed captioning if you do need it. That is also at the bottom of your screen, box with a CC down there. If you click it, you should be able to show a live transcript or do closed captioning, whichever you choose. So that's a lot of talking from me, and I am going to go ahead and hand it off to Andrea.
Thank you so much, Alexa, and thank you to the entire Jett Foundation crew. I am thrilled for this opportunity to share some of my expertise in the hope that it helps the Jett Foundation community, whether you are a parent, whether you are a friend or a loved one of a parent or of a child with Duchenne, or whether you are a provider or kind of in the provider space. I'm very, very excited to be able to share the integral parts of the role of a child life specialist and how we can really partner with you to make your medical experience as in control and non-traumatic and non-threatening as possible. I know that people have not heard of child life specialists. I always joke that we are not mentioned in Grey's Anatomy, and so we often aren't known about. So our kind of educational and professional background, we are master's degree level certified professionals, and are part of the interdisciplinary medical team. So similar to how social workers are seen as ancillary in the medical team, or psychologists, child life specialists are as well in the pediatric healthcare space. Our educational background is in child development, stress and coping theory, and therapeutic interventions. So really understanding the developmental level of children and how we can, in the healthcare space, meet that to enhance psychological well-being and outcomes, which is where that stress and coping theory comes in and those therapeutic interventions come in. And then our role kind of within the hospital or within the realm of healthcare, we're really here to enhance children's coping with hospitalization. We know that Duchenne is a lifelong diagnosis and that there are a lot of stress points along the way. And so our job is to use our background in child development and in this stress and coping theory to be able to support y'all during those stress points. Part of that, what that looks like, is increasing the child's understanding of procedures they're going through and diagnosis. We find that the more children understand, the more they are able to, or the better they're able to cope, and the more they are able to really be in charge or feel in charge of their own destiny and their own treatment experience, and that fares well for everyone, not just the child, but the whole family unit and community unit. And kind of to that point, we're really here for the patient, but we're also here for the family. We want everyone to feel united and to feel that they're walking this path together while they are having their separate experiences. We want everyone as in the family unit to feel that they are tackling this diagnosis and tackling the treatment together. A quick note, because child life specialists are often lesser known in the broader scope of healthcare, we aren't always available in every single pediatric environment, but I always ask that parents, caregivers, family, friends, just ask whether you're at a clinic, in, God forbid, an emergency room, or even at your pediatrician's office. Ask if there's a child life specialist available. And if not, and y'all are still looking for resources, I would always be happy to kind of point y'all in the direction of some private practices or even some online resources that can be really helpful. Hopefully this presentation could be one of them. So I've just spouted a lot of jargon at you, and I'm wondering, okay, well, what's the practical application? You know, what does a child life specialist do? How are they helping me and my child? So I'd like to kind of break it down into what I call the 3 pillars of child life, being play, procedural preparation and support, and diagnosis education. And I want to mention that these aren't necessarily linear. So it doesn't mean that a child life specialist will first play with your child, then provide preparation and support for a procedure, and then educate them about their diagnosis. But these are the 3 main areas that I've found that that the bulk of our work comes in, and where we are the most impactful to the child and family. So let's talk a little bit about play. Piaget, a big developmental theorist, groundbreakingly well known, said play is the work of children. And isn't that the truth? But we know that when children are faced with medical stressors, oftentimes they are robbed of their childhood or normal teenage experiences. And that can be incredibly stressful to their identity and to their coping with their diagnosis. And so our job as child life specialists in providing that play is to really foster those normal childhood experiences, because we know that the more normalcy a child can have, the better off they are psychologically speaking. And so we're also trying to use play to help kiddos reach those developmental milestones, because again, those milestones and that normalcy is so important, and is something that we see the more that we can keep kiddos in a routine, the more that we can incorporate play and fun into their lives while they are facing a chronic illness, the better outcomes they have and the better they cope. And so I'd like to give y'all just a more realistic picture, or kind of day-to-day picture of what that could look like. So these are all things that I have done as a child life specialist. In one of the neuromuscular clinics that I worked in, my job was to, among other things, ensure that our patients and their families, siblings included, had enough things to do for fun to pass the time. We were in an interdisciplinary clinic, and so oftentimes patients and their families could be there up to 4 hours because they were meeting with all of their specialists and all of their support team. And the time in between those clinician visits could lull and get really boring, and then that could lead to feeling tired and feeling cranky. And then those emotions can build and can become hard, because then our pain and our anger can then be pointed towards our diagnosis. And so our goal my goal as a child life specialist was to alleviate that stress potential by providing our patients with age-appropriate activities to do. So for preschoolers, that often looked like Play-Doh and sticker books and puzzles to do. For our adolescents, that looked like bringing in a Nintendo Switch, sometimes with different games. or even some word puzzles that they could utilize. And then for some of our neurodivergent patients, we used sensory machines and other things to make sure that they were staying not only entertained, but engaged throughout their visit. We also noticed that patients were more compliant with their exams when they had the opportunity to take those breaks in between and play. And so I think that just really highlights how play is such a powerful tool in making kiddos feel like themselves and also in helping everyone else, kind of seeing the ripple effect of that. Thinking about those normal childhood experiences, I also placed a lot of referrals to different camps, to Make-A-Wish, to support groups, all that had the purpose of upholding those normal childhood activities and events. My goal was really to let children and their families know what is available to them to be able to continue being a kid, and to kind of preserve those moments of childhood. And I should clarify, when I say childhood, youthhood sounds really odd, but I want it to be known that I'm kind of talking about the whole developmental spectrum. So sometimes that looked like even finding young adult support groups to be able to refer a patient out to, or finding mentor opportunities for young adults as well to be able to provide their expertise about their diagnosis and treatment thus far and how they had coped with that, to give them also that sense of meaning and purpose and the same sense of mastery over their experience that an adolescent or a young adult would have who had achieved a developmental, like, educational milestone. So really trying to provide those normal experiences. I know we don't think of play as necessarily being socializing and holding a conversation, but for teenagers sometimes, and young adults, sometimes that can be the most powerful tool, because we know teenagers are very interconnected with their peers. They are learning about themselves and what they believe and really shaping their worldview. And so sometimes play for them looked like just having that conversation. And finally, in terms of play and really upholding that normalcy, and trying to hold on to that, I was able to, within this clinic, link some families together who both consented and really just wanted support from someone else who got it and who understood. And I know that's also a key component of why organizations such as Jett Foundation exist, which thrills me to no end, because I think the more that we can connect with people who really understand what we are going through, the stronger that we can become. And so that was really a privilege to be able to connect those people and those families. So that is kind of what play can look like. Also, all of this can be transferred to the home environment as well. So I was often giving parents recommendations or ideas of what they could do with their children for fun, and to uphold that normalcy outside of the hospital or the clinic environment as well. So moving on, that was our first pillar. Kind of moving on to our second pillar, we have procedural preparation and support. And I really love the quote, "Preparation is the bridge between uncertainty and coping," because uncertainty, unfortunately, exists in this world, and most particularly, of course, in the medical environment. And so what child life specialists try to do is to mitigate that uncertainty and provide preparation and support, provide actionable items, and help youth to understand what to expect, to bridge the gap and to enhance their coping. So as that first bullet said, procedural preparation informs the child of what to expect from procedures in a non-threatening and understandable way. We know that there are a lot of scary medical words that are used, and our job is to soften that language a little bit and also break it down for the child's developmental level. A 3-year-old understands things much differently than a 16-year-old who understands things much differently than a 24-year-old. And so oftentimes my job was to check for understanding, and if that understanding wasn't necessarily there, to just provide not necessarily new information, but to reframe the information that had been provided in a way that they could understand. Also, when preparing for procedures, it was part of my job to identify what the stress points during that procedure would be. So perhaps it was the needle insertion during a clinical trial. And that was the reason the child was not wanting to go to their appointment, was because simply of the needle insertion for the IV. And when I say simply, I certainly don't mean to discount. That's a very, very scary experience. But of course, if all children in clinical trials were not willing to go because they were scared of the needle, we would have a really hard time enrolling patients in studies. And so part of my job was to come up with coping plans, partnering with the family and the child to find out how we could make that needle insertion or waiting in the chair for the infusion or whatever that stress point was more manageable, so that the clinical trial could continue and we could get the information that we needed and we could deliver potentially life-saving care. Finally, our job as child life specialists, and especially working within the interdisciplinary team, we're there to create that trust between the child and the medical team. We know that, as I've said, doctors and nurses can use really big words because their background is kind of in really big words and in being in and live, but often language doesn't always translate to kiddos' understanding or sometimes even parents' understanding. And so my job and all child life specialists' jobs are to act as a bridge between the medical team and the child and family to make sure that we're all on the same page and we all have a shared understanding that the child is the priority and everything that we are doing is for the good and the help of the child. So again, kind of what does this look like? What's the real world application here? So I have a case example. I'm pulling from many different clients to create this case example. So from a perspective of privacy and confidentiality, I do want it to be known that this is not just one specific child, but is kind of an amalgam of many of the children that I worked with. So I was working with a child of preschool age who was going to be having a muscle biopsy that was going to confirm their diagnosis. They had had some lab work done that wasn't entirely conclusive, and so they needed a muscle biopsy to be able to confirm their diagnosis of Duchenne. And so when during our clinic visit, the child was informed that they would have a muscle biopsy and the family was as well. Understandably, the family had concerns about anesthesia and about the child having surgery at all. This was all very new to them that they were navigating. And so I came in after the physician and I really broke down the procedure into as simple of steps as I could while ensuring that they were still informed, they being the family and the child. And so I shared that they would be coming to the hospital to have a small procedure, a small operation on their muscle. And I was able to use visuals so pictures of where they were going, and shared that they would come to this room and speak to many different people, a special doctor who was going to give them sleepy medicine, some anesthesia, and who was going to make sure that they stayed just the right amount of asleep to where they would not feel any pain, but instead would be just the right amount where they would wake up as soon as the doctor was done performing the muscle biopsy. So kind of just explained the difference between those two doctors, because the word anesthesiologist to a 5-year-old is quite the mouthful. And so explained that and had those visuals of the waiting room where they would be waiting, and then also the surgical suite, and explained that the doctor, the surgeon, or the neuromuscular physician would be making a small cut or a small cut, I believe I used the word cut, into their muscle for the purposes of taking out a small piece. And I used a visual of about the size of a fingernail to let them know, because that child, we all know preschoolers are so imaginative, that child had it in their mind that the doctor was going to take out their whole thigh muscle, which makes sense when we think of, okay, we're taking a piece of your muscle, which is the wording that the doctor had used. And so in a preschooler's brain, in a 5-year-old's brain, a piece is really nondescript. And so they thought that it was their whole thigh muscle. And so I was able to clarify that and let them know it's just a small piece, so small that it would be looked at under a microscope to be able to find out why they had been falling a lot. And so kind of in that way, I clarified some of that medical jargon, as y'all can see on my second bullet point there. They also had questions about other wording, such as getting on a stretcher. They were confused and asked me why they were going to be stretched, which makes sense when you hear stretch her. Makes sense in a child's brain. In our adult brains seems a little bit silly, but that was a real fear, especially because at that point, stretching muscles had been something that had been introduced as a way to relieve discomfort for this child. And so they were very concerned about being stretched improperly by the medical team, since their parents already knew how to do their own special stretches. And so I just explained that a stretcher is a hospital bed on wheels, and really kind of tried to bring that language down to that child's developmental level. I also explained, when giving that kind of anesthesia talk, that so concretely, as I said, the doctor would give them exactly the right amount of medicine to stay asleep just for the procedure and wake up. And that was really important because this child, about 9 months prior, had their dog who had to be put down. And the wording that the veterinarian had used was that they were going to put the dog to sleep. Of course, that's incredibly scary then for a preschooler 9 months later to hear that they are going to be put to sleep. This child didn't think that they were going to wake up again. And that is soul crushing and heartbreaking, and also is no one's fault. And so there I just acted as the liaison and explained things in a way that they could understand. And finally, we were talking a little bit about how the area might burn, the surgical area might burn afterwards. And so I just kind of rephrased that to tell the child in not dishonest terms, but in a little bit softer terms, that it was going to tingle and feel warm where the cut had been made. And that some kids said that it felt a little bit itchy afterwards, but that there would be a Band-Aid on it and it would heal up on its own. There were no extra stitches that would need to be made on the outside, which of course is that child's exact experience. And so just in those simple clarifications, I could see their anxiety really decreased, and the parents and caregivers who are with them, their anxiety decreased as well. We all know how much our well-being is tied to the well-being of our kids. I know I'm preaching to the choir on that. And so I was really able to kind of use that developmental and stress and coping theory in that way. My final role in that was to share the coping plan with the medical team. So I let the physicians know that the word stretcher had been a bit concerning, and that I had clarified going to sleep, and just asked the anesthesiologist if they would be willing to use some really soft and kind language with the child, which he was very happy to do. Sounds like anesthesiologists get that a lot in terms of being put to sleep. So that was great. And that way I could act as the liaison, so the family didn't have to. They could focus on their child, preparing them physically for the surgery, ensuring that they were getting a good night's sleep, that they were spending family time together, and just that they were working on the well-being of their family as a whole, while I worked on the well-being of the medical side. That was a really rewarding time, and all of the kind of children's examples that I'm pulling from really make me so grateful to be able to do this work, because I think it really alleviates those stress points. And that muscle biopsy is a great example, but child life specialists also do this for things like IV placements, or if a child needs stitches while they're awake, or if a child, sometimes it even looks like if a child is doing a physical therapy exam that they really don't want to for whatever reason. Maybe it's painful, maybe they feel like they're losing control and aren't able to exert control over that situation. And so my job in those instances is to prepare them step by step, and to make sure that they're able to conquer each step and then feel proud of themselves afterwards. So I've kind of touched on 2 of our 3 pillars. We have play, we have this procedural preparation and support, and we also have diagnosis education. one of my favorite child life specialists coined this phrase or this saying, children deserve to know what's happening in a way that they can understand. And I know that I have talked a lot already about modifying language for children. And that is really where kind of the bulk of diagnosis education comes from, because Duchenne muscular dystrophy, talking about the genetics behind it, there is a lot that can get lost in translation for children. And so my job in the clinic and in the hospital setting is to really assess their understanding and to help fill in the gaps. And that is really rewarding. So we're breaking down complex medical terminology, diagnosis, treatments, and prognosis into language that they can understand. And so oftentimes what that has looked like for me is either recommending books to parents and caregivers who prefer to be the ones to share the information, or helping to kind of script for parents. I've had many conversations with parents who have asked me, well, what do I say if my child asks if I will ever walk again? Or what do I say when my child asks what to say when kids at school make fun of their scooter or their chair? And so I've been able to provide some guidance to parents in that way as well. Child life specialists are never here to take the place of parents and caregivers, and are only here to equip y'all with the tools that you need to be able to be the best and most confident version of your parentified self. But sometimes it is easier to ask someone to do that while you are there as the supportive presence, the supportive parental presence. I've also made a lot of personalized resources or personalized stories that use different metaphors to explain muscular dystrophy and the breakdown that kind of happens within our muscles in a way that makes sense to those children. So using that developmentally friendly language, and also kind of understanding from a developmental perspective how much information children need to know. Because a 3-year-old, of course, needs to know or has the forethought for a lot less than a 16-year-old is thinking into the future. And of course, we know our young adults are thinking about the rest of their lives and also reflecting on their lives thus far. And so really being able to meet youth where they are at and provide them the information that's most helpful to them regarding their diagnosis at that time is something that I'm really passionate about. And so again, y'all might ask, well, you've given some examples, but what does that look like? And so what it really looks like is just that. So I'm thinking of a time when I met with a youth or a child who, and again, for privacy purposes, this is a little bit of an amalgamation of those patients that I have had the privilege of working with. So this was a 4-year-old who had just received a diagnosis and was really very confused, understood the muscular part in terms of dystrophy. This child had some older siblings who would use the word dis to mean like talking negatively about someone, to diss someone. And so they thought that the doctor was talking negatively about their muscles by saying muscular dystrophy, which sounds very silly. And we also know that kids' imaginations are so full-blown and beautiful. And so I was able to clarify that that's really just a big word that means something different, and with the parents' permission was able to explain just a little bit about that the doctors had found out information that they had a condition or a sickness where their muscles were going to get a little bit weaker over time. They weren't going to be able to grow as strong as the Hulk, but they were going to have to, or they were going to be able to grow strong, but just in a different way. And so we were able to kind of parse that out with parental permission, which was really beautiful. Part of that conversation also, the child had heard the word ambulatory from the physician and was quite confused, thinking that the physician was talking about an ambulance, which makes sense when we think about kind of youth or kiddos hearing part but not all of a word, or being really overwhelmed with information. And so the child was really concerned that they were going to need to utilize an ambulance for all transportation from here on out. and wasn't quite sure that they were going to be able to take their family's car back home. And I smile because it's an endearing memory, and not to make fun of this at all. You know, I don't take these diagnoses lightly. But I was able to explain to that child that ambulatory is a really fancy word that means walking around on our own 2 feet, which is something that in the moment of right after, I mean, 10 minutes after a delivery of the diagnosis, the parents and caregivers were texting, we're calling friends and family, we're talking to each other and trying to figure out what this meant for their family. Of course, they had just been given so much information, and so they were working hard on their end as adults to figure out what to do, and had chosen so gratefully to utilize me as a support in that moment. And so I was able to clarify that, which was really lovely. And then once we were able to come back together as a family unit, I was able to give, again, a little bit more guidance to the parents and caregivers about frequently asked questions that I heard from many different youth, and ways that those parents and caregivers could answer those questions, because oftentimes I think that's really hard as a parent to know. We anticipate the questions, and then we know our adult answer, and then we're not quite sure if that is the right answer to give our child. And if not, what do we say? But also, if so, what do we say? How do we say it? And so I was able to provide some resources to that family to help them in navigating the questions that were to come. And then kind of ultimately in this kind of case example, I was able to partner with the child's school. This was a few years later, and the child had started to use a scooter. And I was able to partner with their school to help the teacher and the guidance counselor understand some really strengths-based and positive language to use, with the parents' permission, about talking to the rest of the class about why Joey was using a scooter. And that went really beautifully. I was really grateful to be able to do that. And then the class was able to understand enough to understand that this is just how Joey's body works, and he uses a scooter, and he's not less than any of the other kids, and he is different in a very special way, the same as other children have blonde hair, other children have brown hair. All of our bodies work differently, and we all have different strength of muscles. And so that was a really kind of special experience of watching the spectrum of diagnosis, or watching the timeline, I should say, from that moment of myself walking into that room 10 minutes after a diagnosis had been delivered, all the way to 2 years later when the child was going to school in a classroom that they had already been in, but were using a mobility device. And so that was really special and really encapsulates a lot of the work that I do. So I know that I have shared those kind of three pillars, as I say: play, procedural preparation and support, and diagnosis education. And I'd like to just share a little bit more about why it's important to educate our kiddos, our patients, because I think that sometimes it feels easier to not talk about the big, hard, scary thing. But there are proven benefits to providing that information, again, just in a way that is palatable for the youth. So an increase in control, we really see this when a child experiences education and understanding of their diagnosis. They feel more in control of their diagnosis, and because of that, they are more able to exert control over their efforts in physical therapy or in doctor's appointments, in terms of answering questions or being able to perform neurological testing. And the more control, I think we all can agree, the more control we feel that we have over our lives, the better our emotions feel, and the better we cope. Which kind of leads me to my second point. The more educated we are, the better that we can cope. And of course, coping is what we are looking for long term, especially because then we can reflect back if and when our ambulation status changes, or whenever the hard times happen, and we can say, hey, you know, we really championed through this experience. And so let's champion through this next experience, this next big scary thing, because you've shown us that you can do it. And we've shown ourselves, we as parents, caregivers, siblings, have shown ourselves that we can also do this. And so why don't we all cope through this together? And finally, we see increased compliance the more a child knows, because not only do they understand the need for whether it's treatment or whether it's frequent conversations with doctors or frequent lab draws, the more a child understands and feels like they're in control of their treatment and of their diagnosis, the more willing they are to comply and the more creative they're willing to get with kind of their solutions for how to make this bearable and manageable. I've worked with many kiddos who are incredibly sick of the number of lab draws they have to have, which makes a lot of sense. But the ones who, the children who have an understanding of why those lab draws are so important, and not just they're important because the doctor said so, but they're important because it tells the doctor how my body is working. And if the doctor knows how my body is working, the doctors can give me the right medicine. And when I have the right medicine, my muscles feel much better. When children and patients can put all of those pieces together, and again, that increases their control and increases their coping, they are much more willing to go and get those lab draws because they understand the importance. And it's not just an adult telling you what to do, which is not to say that if your child is gung-ho about going to lab draws, that is not to say that they are necessarily an anomaly. I really love that. I think that just goes to show that they do feel in control and that they are coping well. And if your child is really hesitant to go to lab draws or any needle procedures, that makes a lot of sense because I know a lot of adults who are not thrilled with needles. And so that's another area, thinking back to that procedural preparation and support, another area where child life specialists can be helpful in advising and supporting you as a parent, or perhaps being there in person to walk your child through the steps of the lab draw and to make each step a little bit more accessible to them and a little less scary. So with the time we have left, I'd love to share a few other hats that child life specialists wear. I know I've talked about these 3 pillars, but we do a lot of kind of, some may say random, but a lot of other things that I think are really important to share in this space. So first and foremost, we are here to support the patient, and we also are here to support the family. And within the family, we know our siblings, and we know that the sibling experience is unlike any other, because there are so many feelings. There are feelings of guilt. Why not me? There are feelings of loneliness and abandonment. You know, what about me? Why am I being left behind? Why am I not able to go to my friend's house because my brother had to go to the emergency room? There are feelings of anger. How could this happen to me? And how could this happen to my brother? And all of those are incredibly valid feelings. And so our job as child life specialists is to hold that space for those siblings and to help them to make meaning of the experience of having a brother with muscular dystrophy. And so sometimes what that looks like is doing a therapeutic intervention, like creating a scrapbook and reminiscing on the good times. Sometimes what that looks like is writing a letter to their brother's diagnosis that no one reads, but they rip up because it's an emotional expression activity. And sometimes what that looks like is connecting siblings with one another. I know that at the Cure Duchenne conference for the past 2 years, I have had the absolute honor of running a sibling workshop that really is tailored to making meaning and connections between siblings. And I know that they also held a sibling session the year prior as well. So have done it for the past 3 years, and I've just been involved the past 2. But as we know, increased coping with our patient, our child with Duchenne, increased coping in our siblings, the family unit coping increases as well. And so we're really here to provide that safe space for siblings. we're also pain management experts. And what I mean by that is that we are versed in a lot of non-pharmacologic pain management tools, such as grounding techniques, which bring us back into our body instead of in a heightened state of anxiety. And we're also experts in knowing what pain management is available to specific children, or I should say, what pain management is available to children during specific procedures. So needle procedures, we know the pain management options within the healthcare setting can look very different from, say, what one would use for a headache. But with those frequent lab draws and those infusions that oftentimes come with this diagnosis, we have many different tricks up our sleeve that include but are not limited to numbing lotions. That's the kid-friendly term. Or Buzzy the Bee, which uses vibration and gate control theory to ensure that pain is not felt so severely in the needle affected area, to shot blockers and cold spray and J-tips and beyond. So we are a wealth of resources when it comes to helping children cope through pain and helping their families know how to support them coping through pain. And finally, we are experts in grief support, because I would be remiss if I didn't mention that this diagnosis comes with grief. It comes with grief of the life that the life that we had envisioned for our child. It comes with the grief of feeling like those milestones are going to slip away or to be replaced by different milestones. And that is so heavy. And our job as child life specialists is to create meaningful and intentional activities and meaningful and intentional experiences to uphold the family unit and to ensure that the grief is expressed in a way that is healthy and that is appropriate and helpful. And so we are here to support y'all in every step of the way. And so I know, as I've said, child life specialists aren't always available in every medical setting, but I do encourage y'all to reach out if you have any questions related to child life, or whether y'all have questions just in regards to how to become connected with resources. I know that, of course, Jett Foundation has so many resources, and that's why they are so very wonderful and why they put on this community webinar series. So I'd love, if there are any questions, I'd love to be able to answer them about child life specialists and the support that we can provide. But y'all can also contact the Jett Foundation as well if y'all think of questions before, or excuse me, after this presentation as well. But overall, child life specialists, we are here to support y'all every step of the way. And I always say, if we don't know the answer, we know who on the medical team does have the answer, and we're happy to get you to that person. So we're here for y'all.
Thank you. Thank you. Thank you. I think that, I think the beautiful thing about this webinar for me is, like you said, people don't necessarily know what child life specialists are. And I hope that this, brings and sheds light to the opportunities for families. So I want to thank you for that. If anyone does have any questions, I know that this was, a 35, 40-minute presentation, and it only covers so much of what child life does. But like Andrea said, even if it's not something that you know of, ask. They may or may not have it, but it also gets clinics thinking, well, maybe I should. And so it's something that I think is really beneficial to families as a whole. So thank you so, so much, Andrea. I do not see any questions on Zoom. Let me check Facebook real quick. I don't see any there either. But again, if you do have any questions, if you are watching this after the fact, if you're watching the recording and you have questions, please feel free to reach out to us and we'll go ahead and get that question to Andrea. And we thank you for spending your time with us and for learning more and helping us spread knowledge. So thank you guys. Have a great day. Bye.
Thank you.